Good morning, Charlie.
Good morning.
Good morning. This is the first in a series of oral histories that we're doing with maternal and child health leaders, and I want to thank you for coming and talking to us. I'm Ellen Daly. I'm on the faculty of the University of South Florida College of Public Health in the Department of Community and Family Health, and you and I go way, way back. And I'm honored that you would come and talk to us about this.
Oh, I'm honored to be asked.
Thank you. So the Association of Teachers of Maternal and Child Health, or ATMATCH, has funded a project to ask maternal and child health leaders if they would, be willing to give us some time talking about their history in maternal and child health, what their attitudes are about things that are sort of, current issues, future issues. And so I wanted to start by asking you if you could tell us a little bit about what you're doing now, how you got involved in MCH, sort of what your history was. Okay?
Well, now I am fully retired and really enjoying that. I still serve on some boards related to maternal and child health, notably the Ounce of Prevention Fund in Florida and the Frontier Nursing Service in Kentucky, Frontier Nursing University now, which trains more midwives and nurse practitioners than any place in the world. And basically I'm retired, and what were you going to ask?
Well, to say you're retired from one of the most amazing careers in maternal and child health. You're trained as an OBGYN, and you went to medical school where?
At Northwestern.
Northwestern, okay.
Which had a great public health department. It had one of the best OB departments in the country at the time. But most of my obstetrics and gynecology that I took was, we could elect where to go, and I always went to Cook County Hospital,
Right.
Which was, at the time, I think it's safe to say, just a totally out of control place. During the first year that I took OB there, we had the most deliveries of any hospital in the United States before or since. In 1 year, we had 26,000 deliveries.
Oh my.
And that was the size of my hometown, Morgantown.
Right.
And that was an impressive number.
How many of you were there? When you say 26,000, how many people were delivering those babies?
Well,
This was your residency?
no, this was medical student.
Medical school. Medical student.
Yeah, yeah. Well, there are about 26,000 people. Subtract twins and triplets.
Wow. And how many doctors and residents, when you saw that as a medical student, some medical students would have run screaming from that and said, 26,000, I never want to go near that again.
Oh no, well, it was, compared to medical students today, we got to do a lot of things, surgery, that, so on. A lot of it was unsupervised, and we actually were thrilled by it. Now some people, just thought it was an adventure, but some of the rest of us really took it seriously and tried to really make it a better experience for people.
Right.
And then the senior year, we had one of the last home birth services in the United States, and so we spent a month in South Chicago delivering babies in people's homes, apartments, tenements, and so on.
Wow.
And that was a real experience. That was crazy. I delivered, well, the woman delivered. I attended a birth at gunpoint. The dad was drunk and said, "This better be a boy." And the nursing student who was helping me, and we were both there, and the woman was back then people had 6.5 babies per family. So some of these folks are having their 10th and 12th babies, and so their labors were pretty fast. And so we kept encouraging the guy to drink more, and he did. And he was in pretty bad shape by the time the baby was delivered, which was a girl.
Oh.
We quickly threw a towel over it and said, "It's a boy."
It's a boy.
And got the placenta delivered and stayed for a while, put him to bed, and
Okay.
got out of there. And I don't think he remembered any of it. But that's the kind of thing that made life exciting. And
that was just when you were a medical student.
right.
Wow.
But I just say that because it really influenced a lot of, what I got interested in later on. Because even though it was an exciting experience as a student, it was a terrible maternal experience for most people. And you could see that a lot needed to be done.
What years were those?
Early 60s,
Okay.
yeah.
Okay.
And then I finished up a little early, and I did an endocrine fellowship. And the interesting part about that is the pill came in 1960, and because it was such a high dose, there were a lot of complications with it. So the whole field of sex endocrinology was sort of starting,
Right.
and that was really interesting to me. And so I sort of was trying to make a choice between internal medicine and endocrinology and OBGYN, but I really liked working with women, so I decided to go into OB.
Lucky for us.
Well,
Yeah.
then I went to Minnesota, and which is a wonderful place where you go from Chicago, which was out of control, to Minneapolis, where people really want to take care of people. And he worked in a county hospital that really tried hard, even though they were busy too, but tried hard to make it, what we would call customer service today, where
Right.
people really got, compassionate care.
Was this in your residency when you went to Minnesota?
Right. Hmm.
So that's such a great juxtaposition of a medical student in this. I mean, it almost sounds like the Wild West.
Oh yeah. it was.
Crazy, right? And then going to a place where, as a resident, you see where sort of policies make such a difference, the setting, the leadership.
And sort of the culture of, sort of the St. Paul was largely German Catholic folks. Minneapolis was Scandinavian folks. Both of them had a culture of, really wanting to take care of the poor. And the only reason they weren't overwhelmed was that most poor people were smart enough not to move there because they'd freeze to death 6 months of the year. But I just point that out because, having that background, my dad was a family doctor in West Virginia, and our first 7 years was in a mining town of about 700 people. And he always said, and I tell students this, that 30% of his people couldn't pay him, but that was the price you paid for the privilege of practicing medicine.
Oh,
And he really eventually evolved into mostly dealing with OB because he really loved it. So the first birth I ever saw, he dragged me out to the hospital and saw triplets being born.
Oh, no kidding.
And then the other thing was that I used to help him. He started the first blood bank in West Virginia, and mainly for RH disease. And so I used to go out in the middle of the night and help him do exchange transfusions on babies because the pediatricians didn't want to have anything to do with it.
Really?
And so I'd count the amount in and keep track of the amount out. And
That's fantastic. How
and
old
that-
were you?
I was in high school.
Really?
And college. I went to college there too. But that's one of the things that's been fantastic throughout my lifetime is that babies dying of Rh disease have pretty much disappeared.
Right.
German measles has pretty much disappeared. Polio, things like that.
Mm-hmm.
But I'm digressing, but
No, that's great. I mean, I think that is amazing to see those kinds of transitions over the years, what things have changed. And sometimes I think, and you and I have talked about this before, that technology has been both sort of a blessing and a curse, and sort of scientific advancement has been, just amazing in the field of MCH, especially when you talk about things like you don't see polio anymore, you don't see RH issues anymore, but then now we have all kinds of problems, related to technology and science.
Yeah, we've sort of overdone our thing, as they used to say in the 60s.
We have.
So after that, after my residency, the Navy had paid a good part of my way through medical school, and then they deferred me through residency because they needed obstetricians and pediatricians. And so I had to serve my 3 years on active duty, and so that was my first paying job, was serving at the Marine base at Quantico during the Vietnam era. And we didn't have enough OBs and peds, so we were really busy. Often we were on call every other night, up all night, see 100 patients in the clinic the next day after doing major surgery. But I think the Marine wives were absolutely wonderful people, and I still communicate with some of them today. But I averaged attending a birth a day, and one major surgery every other day. So by the time I got out of the Navy, I didn't have much interest. I was planning to go into practice with my dad, who died while I was in medical school. And I still was planning to go into private practice, but I just was sick and tired of doing everyday normal stuff. I'd done thousands by that time. And I just wanted something different, and the different was going into academics instead of
really?
It wasn't public health yet, it was academics, but it had a lot of public health flavor to it. So I went back to Minnesota for 5 years on the faculty, and saw some private patients. I was at the county hospital, and then was the head obstetrician for one of the federal community health centers in an Indian neighborhood, and so got to work with Sioux and Chippewa people, and we trained the first Indian nurse practitioner, and they were just wonderful people to deal with, and I still am interested in all things Indian, but
so you got introduced early into this relationship between OBGYNs and nurse practitioners and nurse midwives
yes.
pretty early on. When did that first start with you? Was that Chicago or was that Minnesota?
It was Minnesota because, no, it was actually doing the home birth thing in Chicago. The first week we were on the home birth service, some of the students that had taken their OB in private hospitals didn't really get to attend many births, so they had to be watched more carefully than those of us that had a lot of experience. But at any rate, the first week that we went out to people's homes, a British nurse midwife went with us, because the U.S. wasn't really training many nurse midwives. And they were just wonderful people. And they would show us, I learned so much from them about, following a labor and tending a birth. And then if they said we were okay at the end of the first week, then we got to go out with a nursing student and on our own. But it was neat because I had a really nice relationship with one British nurse midwife, and a couple weeks later she called me up and she asked me if I'd come and stand by while she gave birth at home.
Oh, how
And that was
nice!
neat. You know,
Really?
she just wanted me there in case trouble developed, so
Oh.
I could call the authorities. You know?
Well, that's kind of an honor, isn't it?
Oh, it
That's
was an honor,
great.
absolutely.
That's nice.
It was big. So at any rate, I sort of fell in love with midwives at the time. There really weren't nurse practitioners yet, but they were coming, and they started as pediatric nurse practitioners. But we thought, well, you know, if that works for pediatrics, why can't we do some of that for women's health?
Right.
And so Sally Bolio, who is a Sioux woman, with nurse, we sort of informally trained her, and she did a lot of prenatal care after that, and she was great. So then Bill Spellacy, who was about 5 years ahead of me, he was an instructor while I was a resident at Minnesota, came to University of Miami and and brought Bill and Donna Buhai with him because they were his research people, and now Eric Buhai's on our faculty,
Right.
and going to be a superstar nationally on his own. And they were down there about the time I was at Minnesota, and then Dr. Spellacy was asked to chair the OB department at Florida
Okay.
in Gainesville. And so he called me. I was his first faculty recruit.
Really.
And he called me, I mean, I really loved working in Minnesota. I'll talk about the Red Door. But I'd been reading about this rural health project, and since I'd grown up in a rural area, I was really interested in rural health. But they had a maternal and infant care project that was a federal project. It was one of only 2 of the 60 around the country that were rural, and it served 13 counties around Gainesville. And they'd written some publications about training family planning nurse practitioners and OB nurse practitioners, and sending teams out to the county health departments to take care of moms and babies and family planning. And I really thought that was a neat concept, and we were thinking about how to do that around the Twin Cities. And he called me and said, you know, the fellow who's running that is leaving. I'd really like you to come down and run that.
Oh.
And well, I didn't have to be asked twice.
Really.
I went down to do that with the department is in such a young department that it drove my wife crazy because he couldn't give me an increase in salary. So I went down for the same salary, and my wife's going, "We're going to move, and you're going to have the same salary." I said, "But I really want to do this, you know." But going back to Minnesota, one of the things that happened in the late 60s was never supposed to happen again, and that was an explosion of gonorrhea and syphilis, because we had penicillin and it was never going to be seen again. So they had closed all their VD clinics, as they called them, and then all of a sudden, wham, Minneapolis had a big gay population, and of course, with the pill, everybody was thinking the pill protects you from everything.
Right.
That was a big teaching problem. And so only in Minnesota could you do this. The head of STDs at the state, Hennepin County, and the city of Minneapolis, we all got together because we were the county hospital and said, we're going to have to open some new clinics around here, and let's do it differently. Instead of having old burned out doctors running them, let's run them with nurse practitioners for the women and corpsmen that had come back from Vietnam for the men. And let's set them up to be gay friendly, and let's don't call them VD clinics because a lot of businessmen come in for treatment. Let's name something else. So we called them the Red Door. And we just had a big red door.
Right.
I don't think it fooled anybody, but that's what it was called.
Yeah.
And it was very successful. The first year, and the first one we opened, we saw 19,000 people, and really, it just, my job in overseeing it was every time we had a new case of primary or secondary syphilis, I had to go see it and make sure that that was what that was, because that was more serious than the
Really?
gonorrhea. Herpes came in at that time, and we didn't really have much we could do about that,
That's right.
except get people to use condoms and so on. But so it was very successful and a really good model, and it horrified the medical profession, because here was one doctor and all these other people working, and actually that's been a problem over the years, even in Gainesville. What was I doing supervising 6 nurse practitioners?
Right.
How could they possibly function without me standing next to them?
Right.
So we went before the nursing board a couple of times about that, and said, well, it's either that or the people don't get cared for. What do you...
So the nursing board was critical of that model?
Yes. Nurses are very tough on
They
other
are.
nurses.
I know, that's true. You're right.
Yeah.
So it was more than just the medical board that was critical of that model. The nursing board as well.
Well, it was the medical doctors in Minneapolis didn't like the model. In Florida, the medical board didn't have anything to do with it. It was the supervision of nurses fell entirely to the Board of Nursing. But, well, we had a lot of trouble introducing nurse practitioners to the county health departments, because they'd come with us, and the public health nurses weren't nurse practitioners,
Right.
and they weren't so sure they liked that idea.
Right.
So they'd complain about it a lot. What we finally did was made sure we trained or helped train the county health department nurses to the point that they could easily come back and get a nurse practitioner thing if they wanted, which we encouraged the ones in the big counties like Ocala and
Right.
places like that to do. Or they could do prenatal care when we weren't there. And we calculated that over 10 years, when we weren't there, the public health nurses probably took care of about 220,000 women and never once made a mistake. They'd call us in Gainesville if they had a concern. We'd either have them send them in or whatever, but we'd write up a plan of care. They would follow
Right.
it. If somebody had a problem like diabetes or hypertension, and it's a great model. And that's why I really feel with national health changing now, and more people are going to get care that are uninsured, we're not going to have enough primary care doctors, and it's a great time for nurses to take over primary care,
It is.
because they do a better job for the most part.
It's a great model.
But the docs aren't going to like it, but they could step right in and do it. And so I know that the nurses and the midwives are meeting with Congress this past week, trying to convince them that that's a good model.
You've been a great champion of that model for a long time. I mean, a lot of that's actually one of the ways that you and I got to know each other, and found out, ironically, that I had been trained. I'm not a nurse. I'm not a doctor. I came up through the women's health movement, and that was that same model, that you use nurse practitioners and midwives in clinics to provide primary health care and reproductive health care. And I had been to the Red Door. And when you were the dean here, and I was just getting my PhD, that's how we made that connection, that
Yep.
we actually probably had passed each other when you were at the Red Door. But that model of using nurse practitioners and nurse midwives to provide care, has been so successful. And you've been recognized by so many organizations, as a proponent of that. And it's really tough. I mean, it's never been an easy sell anywhere. I mean, and yet it seems like such an obvious solution to so many of our problems.
Well, I think, like everything in America, unfortunately, it threatens people's income.
Mm-hmm.
It all boils down to that. I know when I was working with the state, and having seen my father die at age 54 of just working himself to death because there wasn't enough help, he probably wouldn't have wanted to use nurse practitioners.
Really?
Now he was really into, sort of the wanting his patients to fall in love with him, I think. And there are a lot of people who go into OB that do that.
Yeah.
But, back at that time, OB was only 5% women.
That's right.
And now it's, 70 or 80%.
That's right.
But, seeing him work himself to death, when I was helping train the residents up in Gainesville, we'd introduce them to the nurse practitioner model, which they worked with. They'd go out to the clinics with us. Midwives helped train them, showing them, here's how to how to take care of a high-risk patient, but here's how women want to be taken care of if they are not high risk. And so we'd sit down with them and say, I'd tell them about getting trampled in the Navy. I'd say, why would you want to go out there with just 2 or 3 OBs and get up all night for routine births and see people for routine pap smears when you could have a really well-trained assistant do that and you could see the interesting stuff and maybe get some sleep. And a number of our residents did go out with that model of practice,
Did they?
2 OBs, 4 midwives, something like that. Some of them didn't, but we tried to say, here's a great model that you can live a long life. You'll make plenty of money, and so will the midwives and the nurses.
Mm-hmm.
But instead of making $5 million a year, you may make $800,000 a year. But I don't know. Some people just have the Dr. Trump.
They do. They do. So let me go back a little bit to when you came down to Gainesville with Bill Spellacy.
Right.
And so you were at UF.
Yes.
Right. And how long did you do that with the rural program? And
Well, actually, I was in charge of it for 14 years, but as we will talk, the last 4 years of that, I was really working heavily in Tallahassee, going back and forth. I had a big private practice too. I specialized in referrals from all over the state and people that had had a baby die.
I didn't know that.
Mm-hmm.
Really?
And then Ken Kellner, my colleague, was built a lot of his research in bereavement, the proper way to take care of somebody. We had a great team that worked on that in Gainesville as a sort of a model for the rest of the country. But sort of out of that, that wasn't all that I did, but I mean, that was sort of my niche area, was that got to be known for that. And then the other thing that our group practice group was really the first one in the South to allow fathers in labor and delivery.
Really?
And so we actually, because nobody else was doing it, we'd have people travel a couple hundred miles from Valdosta, Orlando, and so on to have their babies in Gainesville, because so their husband or their significant other could be with them.
What years was it?
Oh, that was in the mid to late 70s.
Right.
Yeah.
That was a huge change in
Yeah.
practice, wasn't it?
Oh, yeah. And again, it was sort of that thing, I probably was a little harsh saying that about my father, but there was a lot of that going around, was that, you know, get your patients to fall in love with the wonderful Dr. Jones and whatever.
Right.
And so the docs really had to step back and say, we're going to make this a family business, and I'm going to stay in the background unless needed,
Mm-hmm.
which was very hard for some people to do.
Right.
But I thought it made it a lot more fun.
Did you?
Oh, yeah. I just thought, you know, it was fun to see, get the fathers involved. You know, sometimes there was a disaster, you know, we didn't have ultrasound then, and the father would be there, you'd deliver a baby with terrible abnormalities, and, you know, we'd all sort of have to suck it in and deal with that all together.
Mm-hmm.
And right away. And in some ways, I think in the long run that made it easier than the father sitting out there, somebody mysteriously saying, oh, what's happening? Well, the baby's delivered. Well, how's the baby? Well, you know.
Yeah.
So, and then the other reason people came a long ways for a while was that all of us were really had been trained to do vaginal birth after cesarean.
Mm-hmm.
And that was not offered hardly anywhere.
Right.
And people would come from all over the state for that, you know, live in Gainesville the last couple weeks in a hotel.
Did they
Of course,
really?
these were people
Yeah.
that could afford to do it.
Right.
But then that was offered also to our low-income clients that we dealt with out in the county. So
Mhm.
they all got the same level of care.
So all this change from how labor and delivery was practiced, and you know, moving towards natural childbirth, and then getting the family involved, all those changes that come both from changes in practice but also in policy. I mean, you know, letting other people into the room, for instance, you know, that's a big change in, you know, getting hospitals to agree to that sort of thing. So you went through all that. Talk a little bit about, because you are such a champion of this now, of what technology has got us to now in maternal and child health, that we flipped back over to this very high-tech approach, and we have some problems now with things like C-section rates. And what do you think of? It's amazing to me to think of all the changes you've seen and what you've been a part of, and here we are, and now we have sort of a new set of issues that we need to deal with because of technology. And
Well, when you dig into any of those things, it all goes back to money. And, you know, making money drives people to do some pretty stupid things. Taking the various technologies, let's start with epidural. You know, back before the war, most babies were born at home. After the war, they moved into hospitals, and
Right.
women were often put to sleep,
Right.
which is dangerous for the mother and the baby. Then Lamaze, the idea of being awake and aware, came in, and my father was very interested in that. and was one of the first people to refuse to put people to sleep.
Really?
He learned to do caudal anesthesia, which is a difficult technique. Epidurals hadn't really come in at the time. The other thing that he used was saddle block anesthesia, which is a low spinal, and that's what the services use. So in the Navy and the Air Force and the Army, you know, you'd go all the way through labor, maybe get a little bit of IV painkiller, and then only for delivery you'd be sat up while you're ready to deliver. You know, a needle would be put in your back, and you'd called saddle block because you'd be numb around the perineum. But the OBs did all the anesthesia. When I was a resident of Minnesota, whenever we had a very low cesarean rate, it was 4%. And it was too low because we would drag babies out that shouldn't have been born that way. When we had to do a cesarean, it was very difficult to get the anesthesia department to come, especially if a woman needed to be put to sleep. We couldn't do that. And they'd come and they'd complain and they'd gripe and moan, and you know, they had no interest in doing OB anesthesia.
Really?
But then somebody came up with the idea of the epidural. I think it was at the Cleveland Clinic. And this was something that was technically a little difficult to do, and the anesthesia people were doing it. And then came the idea, if we did this in enough volume, we could make a lot of money. And then, as I joke, we went from never getting an anesthesia around the OB unit to actually having them hang out in the OB offices waiting to give an epidural at the first prenatal visit, you know. But so that's how that involved. And then they infiltrated childbirth education classes and just sort of said, this is what everybody does. You don't want to have pain and this and that. And women bought into it. The other big change, well, a couple, ultrasound came along, which I think is the most wonderful technology that we had, because we didn't miss twins anymore, which for like people who are overweight is easy to do. But that's been overused too. I mean, there have been some people that use it as do an ultrasound every office visit, and then they make money off that. And we've had to stop some doctors here in Tampa through the Healthy Start Coalition because they were using up all the women's Medicaid visits just doing ultrasounds. So we had to turn them in to get them to stop. One of the ones that bugs me the most is the electronic fetal monitor. That came in while I was a resident back in the 60s. And that was invented by Dr. Edward Hahn at Yale. And Corometrics was the company that put that out. And they would run ads in Red Book and Cosmopolitan, which were the big women's magazines at the time. And they'd show a picture of a monitor, and they'd say at the bottom, all they'd say is, you want your baby to be normal, don't you?
Wow.
So, so women started thinking,
Sure.
well, asking their doctors, you know, am I going to be monitored? And so pretty soon it became the big thing. Everybody bought up monitors, $5,000 a piece. Enormous medical costs, ruined a lot of labors because the early monitors were very insensitive, and if a woman moved a hair, it would lose the baby's heartbeat. Kept people in bed so they couldn't get up and walk. Really. And then Dr. Thacker and Banta did a huge epidemiologic study after the monitors have been out about 15 years. I can't remember, I think there are 20 or 30,000 people in the study that showed that the monitor had absolutely no value.
Mm-hmm.
And Dr. Thacker was here 5 or 6 years ago to do a dean's lecture, and it was 20 years later, and he said, it really makes you feel good that you do a landmark study and nobody pays a bit of attention to it. So monitors are still being used unnecessarily. It's a huge industry, costs the country billions of dollars, and people argue, well, if we didn't do it, we'd be threatened with a lawsuit. And the other argument is, if you do it and people still don't know how to interpret it, it can be used against you in court. So why bother doing it when it doesn't work? So those are examples of technology gone crazy, and then that sort of helped lead into a lot of unnecessary cesareans. And then the thing that the Child Center is working on now with the Florida Perinatal Quality Collaborative is working with the March of Dimes and the State OBGYN Society, which now has come to realize that the cesarean rate at 36% is way too high. It should be 20% or below. That's costing the state hundreds of millions of dollars, and the country billions. These are things that need to be dealt with healthcare reform, and it's been very hard, but I think we're making inroads into that by showing that it actually, the high rates are actually harming babies and harming mothers, and educating doctors and nurses and families that boutique cesareans or scheduling your cesarean at your first prenatal visit is not a healthy way to go. Some women have chronic abdominal pain from the surgery that they can't get rid of. There's just a lot of bad stuff. It's unnecessary abdominal surgery. It's a big deal. And
it's a huge deal, and I don't know how we're going to solve that, because when you talk to the docs, they say, we're forced into this because of the technology. Like the stuff that you're talking about is, you use that monitor and you start this cascade of something goes wrong, and there's absolutely no way that they're going to stop that and say, no, we won't do that. We'll wait a little longer, and see if we can sort of self-correct. So the docs are saying that, women are asking for it, and they're also forced into a corner because of technology. And then when you talk to women, some of the things that you hear from women are they're encouraged to have it done. And so those days of childbirth education classes, when I think back on when Patrick was born, it was all about empowering you to have as natural a childbirth as you can. And I feel like there's been almost like this sea change in what's happened with obstetrics and women's health. It's really disturbing. I don't know how we're going to back out of that.
Well, I think we are backing out of it. I think, one of the things that happened was that hospitals co-opted the childbirth classes with the epidurals, etc., and then later with how great it is to have a cesarean. But the terrible thing about it is that people are doing this. A lot of the doctors. Well, one of the changes I've seen is that we worked really closely with the pediatricians. We'd have one or two that we would always have the babies that we cared for go to, and they would always let us know if something bad was happening with the baby or the child. And you know, and that was both outside the hospital and in the hospital. Dr. Nelson, who's here, and I worked together closely for years.
Yeah.
And I always knew if a baby was having trouble in the nursery, and I'd go to the nursery every morning before I made rounds to make sure the babies were okay. So I didn't walk into a room and have a mother crying and finding that, you know, her baby had turned blue overnight and they were doing all sorts of stuff to it. That's just not happening today. The OBs are not talking to the pediatricians, so they don't know some of the bad things that are happening because of epidurals, because of cesareans. They don't know that the baby's having seizures because of fever after the epidural. And that's a bad disconnect. So one of the things you're dealing with is, and also some of the docs aren't keeping up with the literature about the bad effects of this. If you look at a lot of continuing education programs, it's about how to use a new technique or a new surgical procedure. It's not about what's happening to your babies. But the big thing is that the parents aren't getting informed consent. And I think the Childbirth Connection and other national groups are really trying to show parents that there are some really bad things that can happen for unnecessary surgery to you and the baby. And they're not being told about that.
How would you correct that in terms of training or policy? You know, when you talk about the thing is, you can have a huge impact, I think, in medical training and in residency. I mean, that's one point of contact where you can make a big difference. Because once the docs are out in practice, it's tough to turn that stuff around because they're in practice. I mean, it's, you know, you can do some stuff with continuing education, but
medical training wasn't doing their job either. Some of them were leading people into the idea of cesareans for fluffy reasons, you know. But it is turning around. I have to say that over the past 5 years, I never thought it would happen, but I've been very gratified. I talked to the Jennifer House, the president of the March of Dimes, when she was here for an event about 5 years ago, and the cesarean rate was up and up and up. And I said, Jennifer, I know the March of Dimes doesn't like to touch this, but you're going to have to take on the doctors, and you're going to have to take on medical practice, because this is bad practice.
right.
Oh, but they did. They absolutely did. And so a lot of what we're using now is our training modules for docs, and it's really, I'd say it's really working well in the northern part of Florida. Tampa General and the hospitals in Tampa have really bought into it, and the cesarean rate is going down. I think in southeastern Florida, Miami, it's a tougher sell, but you know, the Joint Commission is going to start looking at it for accrediting hospitals. A lot of things are coming down that are maybe going to turn around maybe for the wrong reason. You know, people are going to do it because they're going to be affected economically if they don't. But you know, I think it is going to turn around. It's just, but women really have to be involved. And when, you know, as a couple of former students in the room here, they've had that hammered into them that this is their job now.
It is.
And you got to convince women that this is bad stuff, and that it's, you know, going through a normal birth with a lot of good support with your partner there is one of the most wonderful things that can happen to you and your baby.
Well, let's talk about that some more in a minute when we switch to the next 60 minutes.